83-year-old lady presented with a painless gradually progressive swelling in front of the neck for past 4 years. On examination, a nodular, non-tender swelling of size 10 into 8 cm present in thyroid region, firm in consistency with well-defined border and with features of hypothyroidism.
Okay, this general examination and clinical examination. Go to that.
Pulse rate 104 beats per minute. Rhythm irregular rhythm, high volume pulse, no specific character, no vessel or thickening. Blood pressure 130 by 80 millimeters of mercury measured in the right abdominal position. Respiratory rate 16 breaths per minute, thoracic abdominal. She's able
I doubt that you can make a 104 high volume pulse. You could get that? You could count 104 high volume pulse?
Irregular rhythm.
When the rhythm is irregular, getting that 104 counting and saying that it is a high volume. If you have done, if you have seen, it's fine. But it is quite rare, we are not seeing the patient.
eyesight are not present. She has warm, moist hands, no tremors of hands. And
Which eye sign you look for?
Exophthalmos.
What are the other eye signs? Exophthalmos, okay, one.
Related reaction.
No, what is exophthalmos?
The outward widening of the eye.
What is proptosis?
It is the thyroid. It is due to thyroid disease. It's exophthalmos.
What is the pathology behind it?
Retrodulbar in cellular inflammation, increase in fat and edema. It can cause exophthalmos.
Okay.
Proptosis.
It can be due to many pathologies. Proptosis.
How will you differentiate clinically?
Using default test.
What is it?
The upper eyelid can be inverted in proptosis, whereas in exophthalmos,
Why?
because the muscles are spasmed.
Which muscle?
Ocular, liver palpebral superior,
Levator pulmonary superiority will not go for spasm.
superior, Muller's muscles.
Okay,
Okay,
that
what are the other eye signs? One is exophthalmos,
One, lid retraction.
lid retraction.
due to what?
The upper eyelid.
Now, what is the mechanism of lid retraction? Pathogenesis.
Overactivity of the sympathetic part of the liver palpebral superior.
What is ptosis?
Partial closing of the eyelid.
What is the problem there? What is the effect? In Horner syndrome, you get a ptosis, no? Due to what?
When the cervical sympathetic chain is involved.
So, which muscle is lost? Again, the same, same sympathetic overactivity. There is a sympathetic cell.
Okay, lid, other thing is lid, one is the lid retraction, the other thing is
Exophthalmos.
like before lid lag. Okay, then
Can you tell me the eye sign which can present in secondary thyrotoxicosis?
Lid lag.
So, this can be there in both. Lid lag and lid retraction, the sympathetic overactivity can be there in a sympathetic secondary and primary. What is absence of wrinkling?
Chopra sign.
Due to what? Postgraduates? Anybody? Why do you get a Jofra eye sign?
what,
Which?
what actually happens?
Absence of wrinkling.
Why?
Why? So, can you see the top? What is happening in your forehead? You are getting wrinkling because your upper eyelid is almost covered,
It's hiding.
hiding. In exophthalmosis, it is a wide palpebral cut. So they need not raise the foot to see the up. It is a physiology. There is no muscle involvement. Nothing is damaged there. It is only the physiological response. It is happening there. But all other eye signs, there is some pathology is there. Somewhere something is
What's Mobius?
Inability to converge the eyelid.
due to which muscle is it?
Superior rectus,
Superior rectus and
lateral rectus and inferior oblique.
Okay.
okay, go.
No tremor. Okay, right.
How did you demonstrate it? Took for tremor?
Sir, in an outstretched hand, outstretched fingers, we should look for tremors.
Best way?
Sir, place a paper.
Outstretched means like this.
Is it like this?
This, even if I put my hand, can shiver. Because you are doing exercise, you are keeping the muscle tense. This is a passive, it's not on an exertion. You should never keep a stretch. It should be, the hand should be in a neutral, normal position. Then you are going to keep a paper on it. What is tremor? Involuntary.
Movement.
Repetitive.
Rhythmic, non-rhythmic. No, then only, you see, you only saying there is no tremor, and if you are not saying the definition.
Toxicity
And is it a physiological tremor or pathological tremor? What pathology? When you go for examination, the hand will be shiver? That is pathological. That is physiology, this is pathology. How? It's all sympathetic overactivity. You are having a neuronal cells are getting excited. You are going to have. It is why it is called fine tremor. What do you mean fine tremor? Fine tremor, cold tremor. What is the difference? Fine tremor, it can never be in the history sometimes. Patient may not be able to tell. That is why you need to go to the level and putting the paper and examine. So the volume will be low, the frequency will be high. The cold tremor, the reverse. The volume will be high, the frequency will be low. So this is exaggerated physiological response. Go ahead. I think inspection we have covered. No? There is not much. Anything significant on inspectory findings? Nodular surface. So how long is the duration?
So she has a swelling for 2 years and her fever started 6 months ago.
Okay. Go ahead. Can a Graves' disease have nodularity?
No, sir.
Postgraduates.
Diffuse and
Can a Graves' disease have nodularity? Yes. You must read. Can have.
swelling of size 7.8 centimeters seen in the anterior aspect of neck with well-defined borders. Surface of swelling appears to be nodular, extending superiorly up to lateral fascia.
Okay, this is all we discussed. And what is the diagnosis? Okay, what is the toxic symptoms you have?
No, doctor. She had palpitation.
Palpitation. What is palpitation?
Unpleasant perception of one's own heart.
So you are not happy to know that your heart is beating. What is that unpleasant you are having that to know that your heart is not beating? So just because of somebody said palpitation, you are making a diagnosis of THYROTOXICOSIS.
No, sir. She has weight loss and diet. She has.
Picture doesn't look like. We doubt that, except but you said that is a 104 with irregularity. That is something which is, but not anxious, patient is not normal. So a lot of contradictory findings are there. Whether it looks like you have hooked up some findings to.
Is this the case? You found the pulse?
No. That is not. It obviously, see, maths, surgery is like a mathematics. Definitely 1 + 1 is 2 here. So somewhere you make a hooked up, you will end up with a trouble. So you wanted to present a case of a thyrotoxicosis. Okay. What is your diagnosis now? Primary or secondary?
Secondary thyrotoxicosis.
Secondary is right. Okay. How do you going to proceed?
MNG is secondary, multinodular goiter secondary thyrotoxicosis. Okay.
Investigations after sonogram.
Go to the investigation.
Thyroid function test.
Okay. What word you start with the investigations of a thyroid?
So ultrasonogram.
What word?
The breast we say triple assessment.
Here,
anatomic, everything.
Okay, clinical, radiological, biochemical, pathological. Put forth together and you have a quadruple assessment. Okay. Right.
Additionally, biochemistry is added here. Biochemical. In the breast, we have only triple assessment. Here, you are going to have a quadruple assessment. Okay. Why do you want to do thyroid function test?
So to look for elevated T4,
What is thyroid function test?
T3, T4, TSH,
T3, T4. Total T3, T4.
3 T3 and 3 T4.
3 T3, T4. How much is 3 in the total?
What percentage?
50-50?
No, sir. 33%.
33, one third.
I will not asking for ladies reservation.
So it's a very meager amount is free. Now tell me.
0.3 and 0.03. Rest entire thing is bound form. Okay. What is the TSH normal value?
0.3 to 3 milli.
Nanomoles per liter? No. Now you don't get that mole. You have some units, international units. So, milli international unit per? Okay. You have done an. So you suspected toxicosis. So
What value is significant toxicosis? What value among this? Hyperfunction, what is hyperthyroidism or toxicosis? TSH, as such TSH comes in hand for, it's elevated first in or it is changed first? That is for hyperthyroidism, TSH.
postgraduate euthyroid syndrome. Postgraduate is not here or not? We have 9 PGs, no? What is euthyroid syndrome? What is Refitov syndrome? Thyroid function test. What is the difference between reverse T3 and T3? This question okay. Why do you want to do laryngoscopy? Which laryngoscopy? So what now you know that is come to a conclusion that is a THYROTOXICOSIS is there. How you are going to manage? Will you do FNAC?
No, sir.
Why?
It will precipitate thyroid storm.
Thyroid storm. So what? How do you manage thyroid storm?
First, IV fluids are administered. Patient is given oxygen. Hydrocortisone is given. Propranolol 40 milligrams. 1 to 2 milligrams is given.
What percentage of thyrotoxic hyperthyroidism can produce malignancy? Can you get a malignancy in hyperthyroid? Yes. So how do you, without FNAC, how will you know? Original time it was said because of vascular injury which you are going to cause, FNAC is contraindicated. Now with an high-end ultrasonography and sudden increase in size, only 3 years duration, having a huge change. MNG will not turn into 3 years to the toxicity. So you must always do an FNAC, especially in a secondary thyrotoxicosis. When it's a primary, at least you can wait. Secondary, the new concept is under ultrasonographic guidance or the doc guidance, you can do FNAC because now the percentage they say up to 5 to 7% can be malignant, which we cannot miss in the okay. Undergraduate, it is fine. You can say the thyroid function. So how do you start the antithyroid? What are the antithyroid drugs you are going to give?
Carbimazole.
You are writing one for the examination. Carbimazole. If the paper, if you write carbimazole is enough.
10 milligram twice daily. And then once the patient is used
10 milligram daily.
twice daily.
Thrice. Okay.
And once the patient is used we taper the dose to 5
What we call this? See, some drugs we introduce in a low dose and then increase here. Okay.
So suppose the patient is pregnant. What is the advantage of propylthiouracil?
Toxicity is less.
Why do you want to use propylthiouracil?
Carbimazole causes diagonal.
So diagonalitis is easily treatable.
Why it is safe in pregnancy?
No. It is more toxic drug. Propylthiouracil is a more toxic drug than carbimazole. It will not cross the placenta. So that's only first trimester only. The propylthiouracil indication is only for the first trimester because it is more hepatotoxic. So not all the pregnancy in the second trimester, third trimester, you can still switch over to methimazole or carbimazole, but propylthiouracil. What is the mechanism of action of propylthiouracil? What is another indication of using propylthiouracil? One is in pregnancy. Second one is what you said earlier, thyroid storm. Because it has two mechanisms. One is it blocks the peripheral conversion and also the thyroid synthesis is blocking. So that both can be used for that. What is agranulocytosis you said? What will be the complaint? When? When you will get this? What is the lifespan of WBC? What is the lifespan of RBC? 150 days. WBC? 10 days. In average, 7 days. You can say have something is a lifelong something. Platelet? No. When you have a dengue fever, you will do once in 7 days. Platelet count. It's only less than 24 hours. And every 24 hours you need to do the work. So how long you will give antithyroid drugs? Maximum 2 years.
8 to 12 weeks.
What is the treatment of choice for second thyroid? Thyroid.
Okay.
So you can't go on for 2 years. If it is not responding, what will you do? You are giving antithyroid drugs, it is not responding. Corticosteroids. Any other drug other than this? Beta blocker for peripheral conversion. What is the role of Lugol's iodine?
It includes the coupling process in thyroid synthesis.
Have you heard that two terms, Jad Basidos and Wolf Chaikov's? What is Wolf Chaikov's?
So iodine-induced hypothyroidism.
Iodine-induced?
Hypothyroidism.
What is the other name for that? Thyroid?
Constipation.
Constipation. So what you are going to do with the Lugol's iodine?
So 8 loss is given 10 days before surgery. Beyond that, it will make the thyroid hormone level normal.
So that constipation will become diarrhea. So initially you will have an escape phenomenon. So initially you can do that. Then. Okay. Then. What Jad Basido?
So, hyperthyroidism caused due to excess iron.
So what are the, how do you know there is a exogenous thyrotoxicosis or endogenous thyrotoxicosis? What is hyperthyroidism? What is thyrotoxicosis?
Hyperthyroidism increase in thyroid hormones. Thyrotoxicosis is the clinical manifestation that result due to increased hormones.
So there can be endogenous and exogenous. What is endogenous cause of thyrotoxicosis? From any other site you can get a thyroxine synthesis or a thyroid hormone. Stoma ovary. So exogenous?
From increased intake of iodine.
Any rice, any meat which they take? What fish? Hamburgers.
Thyroid gland of cows is eaten.
So now question comes to you, our PGs, you differentiate, how do you differentiate thyrotoxicosis, whether it is from hyperthyroidism or thyrotoxicosis? What is transient hyperthyroidism? 20% of hyperthyroidism can be transient. All autoimmune thyroiditis diseases will produce a triple phase disease. It earlier part produces hyperthyroidism, then it goes to euthyroid, then goes to the hypothyroid. So the earlier part of the first, because the synthesized thyroxine is released, you are going to have a transient hyperthyroidism. So how will you differentiate? A patient comes with a thyrotoxicosis like this and a transient hyperthyroidism. If not you, the PG should answer. How do you know that it is a transient hyperthyroidism or a Graves' disease? There are two methods. One is antibodies. In a thyroid peroxidase antibody will be there in a thyroiditis. Graves' disease, your thyroglobulin receptor antibody. The most sensitive is a uptake scan. When you take a radioactive uptake scan, in a Graves' disease, you will have a vivid uptake, more than 14 to 36%, vivid uptake. In a transient hyperthyroidism, there will not be any uptake because all the follicles have been destroyed. So that is how you are going to differentiate. The second question will be, in a thyrotoxicosis, it can be endogenous or exogenous. That is something which is produced by the struma ovary or something like that, hydatid hormone. Something is by the exogenous, you are giving a thyroid. What is the test to differentiate these two? You need to do the thyroglobulin assay. So in a case of exogenous thyroxine, the thyroglobulin level will be low. It will not increase. But in endogenous, there will be always thyroglobulin level will be also increasing. So simultaneously measuring that you can differentiate whether it is coming from some other part like struma ovary or hydatid hormone or beta histidine secreting, or it is from the exogenous which you do. So these two are very important to differentiate from the Graves to the transient hyperthyroidism and hyperthyroidism due to endogenous or exogenous excessive. There are a lot of difference between JAD-based dose and what is factitious thyrotoxicosis?
Excess thyroxine causes intake.
So what you want to do for this patient? You are done, she has controlled euthyroid. Now what surgery you want to do?
Total thyroid.
Total thyroid. What do you mean by total thyroidectomy? What is the difference between total and near total?
So both the lobes along with the isthmus is removed in total thyroidectomy. In near total, one lobe is completely removed and isthmus is removed, and in the other lobe.
Can you tell me the position you keep the patient for thyroid surgery? What is the
reverse
rose?
tendon.
What is the reverse tendon?
So patient is in supine position. Neck extended with the shoulder.
What is most important? Tendon level. Is a supine position you are going to do or anything else? Supine.
Same thing, cover both legs, head up, leg up, wide. Okay.
What is the disadvantage?
What happens? What's the
You are saying right, the congestion will be less, the flow will be more. But what can be more worse? Huh? The possibility of air embolism. will be very high. Keeping that, it's straight away go to the internal jugular, can go there. So advantage and disadvantage, but still we keep that is the head in the elevated position, the first position. So what we have already discussed of the, you said what are the complications, thyroidectomy?
What are the complications?
Hemorrhage, nerve injury, hypothyroidism, thyroidism, hypoparathyroidism, wound infection,
What is the immediate sign of hypoparathyroidism?
tingling and paralysis.
What is the name?
You have perioral numbness. Then what are the tests?
Citrus test.
Chopsticks
Prostate,
and
What is chopstick?
paralysis,
That is another thing.
what is Trosia sign?
process is carbohydrate pattern.
Where else you get a Trosia sign? No, that is not hypocalcemia. I say that's right. Anything else? Tetany. There is a complication of the same hypocalcemia. Migrating from fluiditis like that. Okay. So what is hypocalcemia? What do you mean by hypocalcemia?
So less than 8 nanomolar.
That's a total. What is metabolically active calcium level? PG is what is transient hypocalcemia and what is permanent hypocalcemia. You have done a thyroidectomy. When you will say it is a transient hypocalcemia, when you will say it is a permanent hypocalcemia. Three days. Very good, good. So up to 6 months it is only a transient hypocalcemia. It is only after 6 months it is persisting. You must, what the different types of hypocalcemia, what is spurious hypocalcemia, vexatious hypocalcemia, hungry bone hypocalcemia, what is normal hypocalcemia. What will happen to the phosphate level? When you have a hypocalcemia, what will happen to the phosphate level? Increase. So what is hungry bone hypocalcemia? There the both phosphate and this will be less. Spurious, in a case of when we are having a patient is having a cirrhosis, his albumin level is low. So it will be indirectly, it will be giving the hypocalcemic effect. Then you should add the value, the albumin level, you should add, that value should be added to the hypocalcemia. Vexatious you get in dialysis, post dialysis, you can get that. So that at least you must know the temporary and so how will you treat? See, the postgraduate examination, the ward round, the questions will be mainly on this and how you are going to treat hypocalcemia, how you are going to treat and the electrolyte imbalance which you are having.